Hey, what's up, guys, and welcome back to Confessions of a Doctorholic. If you're new here, my name is Hafsa, and I'm a general surgery resident. And in this podcast, I share with you guys real life stories from within the walls of the hospital and within the operating room. And today's story is one of those cases where there wasn't a clear answer. Every decision came with a trade-off. And this is where you realize very quickly that medicine is not always about fixing things, but about damage control. So this patient had advanced cancer, specifically a type of cancer that had started in the anal region and had spread. He was actually someone I had gotten to know a fair bit. Very kind, very polite. The kind of patient you remember always, and the kind of patient that you want everyone to be like, which honestly made everything heaps harder. He had already undergone major surgery. At one point, he had something called an APR, which is this big operation where part of the rectum and surrounding tissue is removed. But despite everything, the cancer had continued to spread. He's tried different types of chemotherapeutics. He's literally tried everything under the sun, and he was at his final line immunotherapy. The cancer had reached his groin, and it hasn't been responsive to anything. And then one day he started bleeding from his groin, and not just a little bit, enough that it became concerning very quickly. He's also a really chill guy, so for him to be like, I'm really concerned, this is more bleeding than the ordinary, was pretty interesting. And here's why it was concerning for me personally. In the groin, you have some major blood vessels, and I don't know how to describe this to you. When they say a picture is worth 1,000 words, that is exactly right. A picture is worth 1,000 words. He had huge lymphadenopathy in his groin, and you could literally see through. You could literally put your finger in the holes in his groin. It smells foul. There's wound care involved in there because it had to be cleaned really well. And then on top of that, he was bleeding from there. And I was worried about the cancer invading into his blood vessels, or if it wasn't invading into the blood vessels, then eroding that area. So I remember thinking, okay, what are our options here? Because this isn't a simple bleed. Either way, I was applying pressure. It wasn't pulsatile. So I was like, okay, since it doesn't have that pulse-like appearance, it's probably not the artery. It's probably like a venous ooze. But it wasn't something that I could just like slap some pressure on and walk away. We had to deal with it. So I was thinking of it and I was like, okay, option number one is literally blocking the bleeding vessel. So it's something called embolization. It's usually done by our interventional radiology friends. You literally go in there, you put a coil in or something, and it just blocks the blood vessel. But then, here's the problem. If you block blood flow in that area, I'm risking cutting off circulation to the leg. That means down the line, he's losing that leg entirely. The other option in my head was to stent it. So what people can do sometimes is you literally put like this cylindrical metal device, which keeps the vessel open, but blocks external bleeding. But that also comes with its own risks. It's a foreign object that we're putting in the body, which can get infected or the cancer can occlude it. So it has its own complications. And then you're in this situation where if you stop the bleed one way, you lose the leg. In another way, you're risking infection and failure. And the third option is do nothing, which is also a really tough pill to swallow and really not an option when this patient's bleeding. So luckily for us, the patient stopped bleeding with pressure. So once again, not thinking it's arterial, it's probably venous, which can happen sometimes. And there was this sense of relief, but the concern was, what if it happens again? I do not want this patient to deal with this devastating bleed again. What if it's worse? What if the invasion keeps happening and it's significantly worse? These are all valid questions and questions that I discussed with the attending. So he was admitted to the hospital because obviously these situations come overnight. So he was admitted, and we were talking to the J team. We were talking with vascular surgery as well to see if there was something else surgical that we could offer this guy. And our fears came true. It came back. The bleeding came back with a vengeance. It was heaps worse. And at that point, the team made the decision to do both. They put a stent in. The stent did stop the bleeder, so they ended up embolizing anyway because we had to control the bleed. This was the thing that was life-threatening for him. And this stays with you because it's such a difficult situation to be in and know that the options are limited. Sometimes it's about mitigating the risk, balancing the outcomes, and doing the best that you could in a possible situation. And what made this case even more difficult was who he was as a person. He wasn't just the patient with cancer. He was Mr. X, kind, grateful, extremely polite. You walk in there, no matter who you are, and he thanks you, even if you did nothing, even if you literally just took the rubbish out. He was like so grateful. He trusted us. And when patients trust you, it just feels a little bit heavier. So, confession of the day. Some of the hardest moments in medicine are when every single option feels subpar or feels like the wrong one, but you still have to go with these choices. So I want to ask you guys something. If you had to choose between two difficult options, one with risk, one with a different kind of risk, how do you make that decision? If you've had to make that choice in the past, how did you come to an answer? Let me know. Alrighty guys, I'll leave you guys till next episode. Have a good one.